Hey everybody, today we're going to go through the pharmacology of the antihypertensive drugs, which is a particularly important topic in medicine today. Hypertension is the definition of a reproducible measurement of elevated blood pressure. It's really dangerous because it's asymptomatic. A lot of the times it's chronic, so people develop this over like 20 years. They get used to the high blood pressure and they don't feel anything. The chronic hypertension leads to a lot of organ damage, in particular the kidneys and the eyes, and it really increases the risk of stroke, myocardial infarction, heart failure. So everybody knows that below 120 is like pretty normal. We start getting worried when somebody's blood pressure gets into like the 139, 140, over 80 or 89. And then the hypertensive crisis is of course higher than like 180. It sounds insane, but there are some people that part of it is just not managing their blood pressure and having poor diet along with having bad genetics. Some people come into the ER and their blood pressure is like 200. So the renin-angiotensin aldosterone system occurs because renin is secreted by the kidneys. Angiotensin is going to be converted to angiotensin 1 thanks to renin, and then from there, ACE is going to convert it into angiotensin 2, which has all these effects. So it's going to increase ADH secretion, it's going to increase arteriolar vasoconstriction, increase aldosterone secretion, and all in all increase sympathetic activity. So it's all kind of feeding back. So feeding back to the brain to increase antidiuretic hormone, increasing aldosterone production. And all of this feeds into the heart, which increases blood volume, cardiac output, increasing the arterial blood pressure. So all of this will raise the blood pressure. The system is overactive in patients with hypertension, of course, and in a person with controlled blood pressure. An increase in blood pressure will decrease the renin secretion, of course. Water retention and salt will also inhibit renin production. But in somebody with heart failure, this kind of system right here, this feedback loop is cut off. So ACE inhibitors end in pril. The important ones you need to know are lisinopril, captopril, enalapril, and the angiotensin antagonist or the angiotensin receptor type 1 blocker will end in artin. Or sartan. So the important one that you need to know is losartan. The calcium channel blockers will end in dipines, except for verapamil, diltiazem, and the rest. Nifedipine, amlodipine, clonidine. These are the ones more commonly used in the hospital, amlodipine and clonidine. Other drugs will be used in tandem, so diuretics such as thiazide-like drugs, and potassium-sparing. Beta-adrenergic blockers, propranolol, atenolol, bisoprolol, acebutolol, or remember which ones are selective, which ones are non-selective. The alpha and beta-1 adrenergic blockers, labetalol and carvedilol, can be also used. The alpha-1 adrenergic blockers will end in zosins, so prazosin, terazosin, doxazosin. The centrally acting sympathoplegic, Clonidine, methyldopa, vasodilation drugs, hydralazine, minoxidil, sodium nitroprussides, Dopamine D1 agonist, phenyldopa, anything that ends in dopam really, and the renin inhibitor aliskiren. This is a lot more expensive. This is newer. So all of those are basically used to treat blood pressure. So ACE inhibitors will inhibit ACE in the lungs, and more importantly, inhibits the conversion of angiotensin 1 into angiotensin 2. They're contraindicated in people with pregnancy because this can lead to oligohydramnios, hypoplasia of the organs, and teratogenicity. It can also cause the renal failure in renal artery stenosis and hereditary angioedema. The ACE inhibitor side effects would be captopril, so cough, angioedema, or agranulocytosis, which is why this is not good in anybody with like hereditary angioedema problems. It's just going to worsen it. Proteinuria and potassium excess, taste changes, orthostatic hypotension, pregnancy, renal artery stenosis, increases renin, and liver toxicity or leukopenia. So the dry cough occurs because the bradykinin release is going to irritate the lung alveoli, and the hypotension and the postural hypotension will result in the headache and the dizziness. Angiotensin receptor antagonists are going to block angiotensin 2 receptors, also known as type 1 receptors. So they have the same adverse drug reactions as the ACE inhibitors, except the dry cough. Like, they're not going to have the dry cough. They have the same contraindications, and you cannot combine ACE inhibitors or the ARBs with the potassium-sparing diuretics because it's going to increase the potassium levels in the blood and lead to bradyarrhythmias. So the renin inhibitor is going to inhibit renin here. ACE inhibitor is going to inhibit ACE1. And the receptors, ATR or ARBs, are going to inhibit the angiotensin 2 receptors. So with the angiotensin 2 being blocked, there's not going to be any vasodilation. There's going to be inhibition, or there's going to be increased cell growth and increased cell survival. So both ACE inhibitors and ARBs will dilate the efferent arterioles in the kidneys. It's going to be good for diabetics because it increases glomerular flow rate. It doesn't allow the deposition of the metabolic products. It's going to decrease the glomerular capillary pressure, the proteinuria, and thus it protects the glomeruli. It's contraindicated in renal artery stenosis because it's going to increase the flow, and with the stenosis, the diseased kidney isn't going to be able to both distend and contract. So the elasticity is going to be gone. NSAIDs will constrict the afferent arterioles, and used with the ACE inhibitor, it's going to cause the renal failure, so not good to use together. Calcium channel blockers will dilate the arteries and the arterioles, and they have very little ability to decrease the AV node conduction, so actually pretty good to treat a kidney disease that's separate from heart conditions, right? So diphenylalkylamine, also known as verapamil, and benzothiazepines or diltiazem. Dihydropyridines are going to be your nifedipine, amlodipine, phenolphthalein, nicardipine. So nifedipine isn't really used too much because it has a lot of adverse drug effects, and amlodipine is more used because it has a nice long half-life actually. So the dihydropyridines are not going to have any effect on ionotropy, so it's not going to have an effect on contractility, while diltiazem and verapamil does. So it's going to decrease the contractility. It's also going to slow the heart rate, and it's going to slow the effects on the AV node, so the heart is able to like fully contract and like squeeze out all of the blood. So it's actually non-dihydropyridines are actually like better drugs for heart problems. Okay, so how do they work? They bind to and blocks the calcium channels. Calcium can't enter, so there's going to be forced vasodilation. Which channels do they block? L-type calcium channels. Importantly, the skeletal muscles are not affected, and the verapamil is more selective to the heart, and nifedipine is more selective to the vascular smooth muscle. So this one you have to be careful about. So they are used for conditions that can lead to like vascular resistance or vasoconstriction, hypertension, Prinzmetal angina, renal syndrome. Dihydropines has more effects on the vasodilation, less effect on the heart. Non-dihydropine has less effect on the vasodilation and more effect on the heart function, so it depends on what the patient needs. Okay, so the adverse drug reaction of the calcium channel blockers, they are very nice drugs, so verapamil, nifedipine, and diltiazem. Side effects: decreased blood pressure, bradycardia. It could cause an AV block, headache, nausea, flushing. Verapamil will cause constipation in particular, and nifedipine or niferidine, I think I've been pronouncing it wrong the entire time. It will cause ankle edema and gingival hyperplasia. It can also cause like systolic heart failure and atrioventricular block, so we need to be careful about these drugs. Beta 1 blocker, we've been through this before, but let's just go through it again. It's going to decrease the renin secretion and decrease angiotensin 2 and aldosterone. Not used really because of the CNS effect, which can be pretty bad. Besides the bad effects, it's not desirable either. It's also dangerous because it can hide the hypoglycemic signs, and if you take it away too fast, it can cause rebound hypertension, which can lead to a hypertensive crisis. Non-selective propranolol and nadolol should not be used in asthma and peripheral vascular disease because they will react on the alpha 1 or alpha 2 receptors. And nebivolol will make nitric oxide. Metoprolol and atenolol are not going to be used in heart failure and peripheral venous diseases or peripheral vascular diseases. We don't want the contraction, right? So the cardioselective beta blockers, remember them as MANBABE. So B1, heart. There's only one heart, two lungs. So B1 is heart. MANBABE. Metoprolol, atenolol, nebivolol, bisoprolol, acebutolol, bexazolol, betazolol, and esmolol. Sorry. Okay, so beta and alpha 1 blockers are the second line drugs. Carvedilol is going to be used mostly for hypertension. Labetalol is the first line treatment to treat gestational hypertension. It's FDA approved. Other drugs are nifedipine, methyldopa, and hydralazine. So I remember it as labs hide meth knives. So labs labetalol, hide hydralazine, methyldopa, and nifedipine. All of these are medication that can treat gestational hypertension. ACE inhibitors, along with the AKBs and the diuretics, are all contraindicated. Alpha 1 blockers are going to be your second line drugs. So zosins, prozosine, terazosin, doxazosine, and tamsulosin. Remember, tamsulosin only in benign prostatic hyperplasia patients. Adverse drug reactions. The postural hypotension is going to really get them, and the edema. So they are going to block the contraction of vascular smooth muscle. Okay, so central sympathoplegics. Clonidine and methyldopa are going to be the A2 receptors. Blocking those will decrease the sympathetic outflow. Clonidine does not regulate the glomerular filtration or the renal blood flow, which is pretty good actually. Adverse drug reactions, there's going to be the rebound hypertension thanks to the receptor upregulation, sedation, constipation, impotence, and bradycardia. Methyldopa will cause sedation, drowsiness, and positive Coombs test. So there's going to be antibodies against it. Not good. So this is clonidine. It's going to increase the firing of the vagal nerve. It's going to slow down the heart rate and decrease the firing of sympathetics. It's going to work on the depressor side of the vasomotor center. So it's going to decrease the venous return, decrease the total peripheral resistance, decrease the heart rate and the stroke volume. And all in all, decrease the blood pressure. So pretty effective. Vasodilators, hydralazine, and midazolam are going to be your second-line antihypertension drugs. Sodium nitroprusside are going to be used in hypertensive emergencies. They're used to dilate the arteries and veins. Hydralazine will dilate the arteries and arterioles by releasing nitric oxide. Water and sodium is going to be retained. The heart is going to beat faster to compensate. Hydralazine and the beta blockers are going to be used to treat gestational hypertension. Remember, labs hide meth knives. Adverse drug reactions, always with the headaches, tachycardia, angina because of the tachycardia, lupus-like syndromes with high doses because of the Coombs test is going to test for that. Minoxidil is going to cause hyperpolarization. The heart's going to beat slower. It's going to dilate the arteries, and it's going to cause excessive sweating. It can also be used to treat baldness, and finasteride can do the same thing. It's not just this is not the excess sweating. This is going to be excess hair growth. So topically can actually be used to treat baldness. Nitroprusside will dilate the arteries and venules by just releasing nitric oxide. It is going to cause palpitation, cyanide poisoning, and lactic acidosis in high doses. And in overdose, you treat them with a nitric oxide nitrate along with sodium thiosulfate or hydroxycobalamin in order to chelate. So remember, with the hydroxycobalamin, there's the cyanomethemoglobin, and it can be converted into the thiosulfate so it can be excreted. Okay, so dopamine D1 agonist works in the kidney. Phenoldiazepam is going to be used to treat the hypertension emergency. The renin inhibitor aliskiren is going to directly inhibit renin formation. It's effective, but there's a lot of adverse drug reactions, and it's really expensive. The important drug reactions are the diarrhea, angioedema, and the hyperkalemia. Hyperkalemia, of course, can lead to arrhythmia. Sildenafil is going to treat prostatic hypertension, and it's a phosphodiesterase 5 inhibitor. Bosentan is going to treat the same thing. Instead, it's going to be an endothelin antagonist. And epoprostenol also treats the prostatic hypertension, and it's a PGI2 analog. So these all kind of do the same thing, but they have different mechanisms of action. Okay, so compensation. Thiazides, loop agents, beta blockers, ACE inhibitors, and ARBs have minimal responses. So the central acting antagonist nitroprusside is going to result in sodium and water retention. Alpha-1 blockers, hydralazine, and minoxidil will also have sodium and water retention along with tachycardia. So this one you have to be a little bit more careful about. So first, to manage hypertension, of course, diet and exercise, lifestyle. You start with one drug and you add more. So first we want to start with vasodilators, and then a diuretic, and then something that really targets the heart. First line treatment is going to be your ACE inhibitors, alpha-1 antagonists, diuretics, and the calcium channel blockers. It's all going to really depend on the patient, right? So in the JNC 8 guideline, the first line treatment for angina is going to be ACE inhibitors, then beta blockers, then calcium channel blockers. In diabetes, got to consider something else. We use ACE inhibitors or angiotensin receptor blockers, so ARBs. For heart failure, you use the ACE inhibitors, ARBs, beta blockers, diuretics, and spironolactone. Post myocardial infarction, you want to give beta blockers for prophylaxis, ACE inhibitors and ARBs to treat. For the benign prostate hyperplasia, alpha blocker, tamsulosin. Dyslipidemia, you want to decrease the blood pressure, of course, so you're going to use the ACE inhibitors, ARBs, calcium channel blockers, or alpha blockers. So chronic kidney disease, you are left with only two choices, ACE inhibitors or ARBs. And in pregnancies, labs hide meth knives. Hydralazine should be in here. So this is the guideline in a chart. Okay, so hypertension emergency. Malignant hypertension can be due to impending or progressing target organ damage. You have to treat everything using IV. A mean BP should be lowered like steadily, but not too fast. You can't lower it more than 160 over 100 because of the cerebral hypoperfusion. So how do we manage that? We use the nitric oxide vasodilators. So sodium nitroprusside is going to be your big one. Nitroglycerin to treat the angina and the pulmonary edema. Next, you give the calcium channel blockers, nicardipine to manage like the neurologic symptoms, and clonidine. The adrenergic receptors antagonists, phentolamine, esmolol, and labetalol are going to be used. Next is the vasodilator, hydralazine. And then lastly, the dopamine agonist, phenyldopa, work on the kidney to increase urine output, to also help decrease the blood pressure. Resistant hypertension is really tricky to treat. You really see it in people of African American descent, people who are of like Alaskan Native descent too. Usually it's like a 3-drug regimen that includes a diuretic. The causes for those groups are genetics, but in other ethnic groups it would be because of excessive alcohol intake, diabetes, and hyperaldosteronism. Along with a mix of medications, so sympathoplegics, non-steroidal anti-inflammatory drugs, and antidepressants will also cause it. All in all, you always have to consider pheochromocytoma. So that's it for now. Thank you for your attention, and good luck studying.